Manuel, join me now, tēnā kōrua. Thank you for your time. So here we are, the two wahine with the task of overhauling our lumbering health system. Margie, to you, do you regret taking the job already?
Absolutely not. Absolutely not. It's a privilege, and we're really humbled by how many people in the system are telling us, it's tough, but we need to get on with it.
Right. Rihanna, it's a new job.
Brand new.
Brand new job,
building
okay.
it up from the ground up.
Okay, so are you daunted by the challenge?
No, and I'm like Margie. We have a saying, "Nōku te whiwhi." It's my honour to be able to take this job on for the first time. But more importantly, I'm excited by what we can do in this space and creating an opportunity that we haven't got currently.
All right, Margie, how would you describe our health system right now?
Oh, it's a tough time, Simon, for our health system. But going into COVID, we were already challenged by workforce demand growing from our populations. And so COVID has exacerbated some of the challenges that we were dealing with beforehand. So
it's a tough time.
Yes.
Andrew Little has stopped short of calling it a crisis, but I would suggest to you, Rihanna, that for Māori, it is a crisis.
I think for Māori, we've been a long time in this space, and so the Māori Health Authority is an opportunity to really make a difference. And that's what I kind of keep coming back to. Māori Health has been in a poor state for decades. It's not a new thing. So this is a really intentional move now to make sure that we deal with that. So
would you use the word crisis for Māori Health?
I would use the word that we've got work to do in Māori Health, and this is the starting.
It's a very diplomatic answer. Are you the right person? Are you the right champion for the job?
Absolutely. I come from the community. I come from I've been on the front line nearly all my working career. I know how to manage spaces, to drive innovation, and to make sure that we push equity to the front of the table every time.
So why don't you think it's a crisis then?
Because I think that if we get caught up in the semantics of what is a crisis, what is not, I think I've made it clear that for decades our people have been in a poor state of health and well-being.
Right.
And I don't tend to focus solely on the presence of disease. I want to focus on the presence of well-being.
Okay, well-being is a long-term project. This is a long-term project. I think we'd both agree on that. What is your first priority first to you, Margie?
Well, our priority will be to work on workforce. The staff shortages and how we can take advantage of being one organisation that can coordinate activity, support shifting of resources to support workforces while we are building a pipeline of more people coming into our system.
Right, so Rihanna, is that your first priority or what is yours?
Yeah, so I believe we've got some really good things we can do quickly around workforce development. So for instance, during COVID we saw the Kaimanaki workforce really rise up and take on some of those tasks that I think will be helpful for us in terms of
Are you talking about with the help with the vaccination program rollout?
Absolutely, PCR roll-up. So that was an opportunity to micro-credential a specific workforce to bring in additional help.
Right.
So it's not trying to replace anything, it's actually trying to put some additional hands in the game to say, well, what else could we do with a workforce like it? Childhood immunisations might be an opportunity. A whole range of tasks.
Yes. Margie, Andrew Little, I think I saw you quoted as saying he's given you some immediate targets and he's going to hold you accountable. What are they?
Well, workforce is one of those important initiatives. The Minister has said to us we need to improve workplace culture, and we know our staff and our management and our leadership need to create workplace environments that make it easy for our frontline staff to do the right thing and do their jobs. Innovation is a really big agenda item for the Minister. We know that, with 20 district health boards, and Diana and I have been visiting, we've covered almost half of the districts around the country, there are gems of innovation and improvement that we need to lift up and get much more quicker at spreading across the country. So let's talk about innovation and the disparate nature of the previous structure. I mean, doctors want one electronic patient management system. It seems crazy in a population of 5 million that we don't have that. I agree. And there are jurisdictions around the world with populations about our same size that have electronic patient record systems. It might take us some time because we are going from a number of fragmented systems. Some regions have managed to do quite well in having them talk to each other, but not to the extent that we need for a country our size.
And in terms of data and Māori, Leanna? I mean, is that a real sorry, I'm really sorry I used that phrase, but a real gaping hole is what I'm trying to say there. Is there a system where the Māori data is just not accessible?
I think that there's a lot of data, even for Māori. The problem is the health analytics, or the analytics and intelligence we now have to apply to it. So making sure that we get that data, that we understand what it's telling us, and actually we do something about it. So, that's going to be our big focus moving forward, is that we don't just want to gather data, we want to be mindful that the data is telling us something and get on with the job.
Margie, you're a specialist in local solutions previously, hard-to-reach communities. Is that where your focus is going to be in service delivery? That's hyper-local?
Yes, and it's about tailoring and having a diversity or a range of ways that we reach into local communities without having, we need the right balance of national and regional settings that are enabling those models. Every community is different, and so we need to be able to respond to
Can you do that? I mean, you're centralising everything, but you're proposing a decentralised delivery model. Can the two exist?
So that's the trick for us. We need to centralise the right things that make it really efficient for us. So there are a number of things, for example, finance systems. We don't need 20 of them. We need one across the country. There'll be a whole range of things. Data digital, we've just talked about. We don't need 20 different clinical systems. We need maybe one, maybe four of some things. And what that will do is free up time and automate, and what we're aiming for is to make it much more efficient for our frontline staff to get the tools they need to do that work on the front line.
Right, so we're talking about frontline staff, but we're also talking about remote provision here, Rihanna, aren't you? Is that where you come in?
Yes.
As an organisation, are you the service buyer, the service provisioner for those remote services to tie into Health New Zealand? So
the Māori Health Authority will have both a commissioning and a co-commissioning function, as well as partnered commissioning functions. So our aim is to make sure that wherever our people are, we're going to get services closer to them. And I think you've heard quite a bit about this recently. We saw it during COVID, mobile services that go back out into those rural and remote communities. There's actually a lot, like Margie says, that we could do if we were doing things smarter. So using wearables, using innovation, using digital technology to make sure that when we send those mobile vans out there, they're kitted up with everything they need, as well as the workforce to be able to go to our people and not have them lining up outside clinics, because at the moment we've got people waiting for hours on end, either inside primary care practices and or ED, and we want to get our people out of there to take the pressure off the front line at ED, so we can do a lot more mobily. Right. And this is something we can do fairly fast.
A mobile workforce. A mobile delivery.
That's right, and it's already happening. We saw it happening during COVID. I know that for most of the kaupapa Māori providers, they now have vans and services that can go further. They're out in car parks, they're doing drive-through settings. So let's just build up on some of that, because it'll take the pressure out of those other areas.
Margie, you're responsible for the other end, though, the other end of the spectrum. That is the specialists, the doctors and the nurses, and the shortages that are being displayed all the time. I mean, how can you get those people on board reasonably quickly, because it is urgent? We have people waiting more than 4 months. It's double the wait time, 4 months, for their first specialist appointment.
And look, that's going to need much more collaboration across regions than we've ever had before. Every hospital runs their specialist services. Some have tried to build regional clinical networks. And what that does is they help us have more greater visibility over what access our population across a region is having. So if I just take an example, in a region, I won't call them out, but in a region, there'll be a couple of districts whose people will almost have to lose their licence before they get an ophthalmology or a cataract, and other districts in that same region that are getting care earlier in their disease. And so we need to look at regions as a whole, and share those resources across hospitals to get equity of access across the region.
OK, so will that equity access come with the same amount of resources and same amount of staff you have, or are you going to have to employ a lot more people? We
need to do a bit of both, but it takes time to grow doctors, and it takes time to bring our specialist services together to work. But certainly the immediate opportunities we've got is to get regions working together.
Right, so you want to streamline the service. Let's talk about postcode lottery of health. That's what you're referring to there. I've got an example which came to us. It's an anorexic child in Hamilton. Can't get specialist care in the eating disorder unit in Starship in Auckland because they're from a different DHB. What will change under you?
Well, certainly we have a number of national services like that where we have a very poor national planning to support the growth and growing the workforce for those specialist services. These are services that have a very, very small workforce, highly specialised, but what we've had to date is a very fragmented way of planning them. We've relied on DHBs or regions to do that. And again, the opportunity of being a unified system is we can look at those services and be intentional about growing them for the country.
The Chair of Health New Zealand, Rob Campbell, has said that some of the new approach will be a shock internally and externally. What does he mean by that?
Well, we are a system that's, before yesterday, had 30 entities from district health boards, shared services, subsidiary companies who've all worked with independent boards and focused on their individual purpose. The shock for some, and look, I want to acknowledge that there have been lots of efforts over time to try to work collaboratively, but actually sharing resources, having visibility of what each entity has, that will be a shock to people because some people might realise that they may be less needy than others when they see other districts or other populations' need become more visible. The
Health Minister on this program has said that it could mean bureaucracy is going to go. So that means jobs, doesn't it? Is that what's going to happen? We'd
like to see, we do want to see some efficiencies in the way that again,
so that's a yes,
there are functions that we don't need to do 20 times, that we'll bring them together and do them once.
So when will you identify those? What's the time frame?
We're working through that with the people who have the expert knowledge at the moment.
Right, OK. Starship, will that become a national service?
Starship already is a national service.
It already is.
So it does provide some services.
From South Island already?
Yes. Okay. There are some very, very specialised areas.
And is that the model that you want? You have those regional, they're in the regions, but they are national services, whether they be in Auckland or Wellington or Christchurch.
Yes, and there are national services that are provided by other district health boards. And again, we've planned them in a very fragmented way, and we need to bring them together and look at how we can intentionally support the growth of those services. Right,
let's talk funding. I'm not going to talk your funding. You've got billions. You've got $168 million over 4 years to purchase Māori health services. Is that correct?
No, because we have $350 million of existing contracts that we commission as well for the kaupapa Māori providers. So collectively, there's about $535 million that the Māori Health Authority will be...
So was that additional in the budget?
That was already existing contracts.
So the $168 million is additional to that over 4 years? Correct. OK, so is that enough? All of it? Is that enough?
There's never enough money in health, but there's also not a never-ending pool of it either. So what we've got to do is get what we've got and start getting on with how we can be really effective, make the most impact. But I just want to caution too that there is also Health New Zealand, or Te Whatuora, and our job is to co-commission and reach into those spaces because about 85% of the Māori population access services through Te Whatuora. And so our job is to make sure that we get in there and make sure that prioritisation, equity, and that te tiriti focus is being worked on.
So let me be really clear, Simon.
Yep.
The Māori Health Authority funding is in addition to the resource that Te Whatuora applies because Māori access services across our whole system. And while it's not a tidy, elegant unbundling things for the Māori Health Authority, we have an accountability and a responsibility to deliver to Māori wherever they turn up in the system. Right,
so it's not going to be streamlined for on ethnicity, which has been the common sort of, allegation from some political parties. Is that right? I mean, what I'm saying is that you're not going to separate healthcare based on race because it's the Māori Health Authority.
No, we're going to prioritise where we see, and it's not just for Māori, for our Pacific population, for our people with disabilities. There are a whole range of communities that we need to prioritise and focus on at the same time. But the Māori Health Authority is a very deliberate te tiriti function that sees us in partnership, which means we've got to share the services, share the pūtea and share the opportunity.
But again, Māori turn up to pharmacy, to general practice, to community services, to hospitals. So the whole system.
So how will it benefit someone who is Māori from turning up to a healthcare system under you guys? How's it going to be different?
Well, we'd like to think that through the Māori Health Authority, they're going to have a choice to access care through the providers and services that we strengthen and support and grow under the Māori Health Authority, and that our job as Te Whatuora is to grow the responsiveness and our ability to connect up that care and make it easier for Māori to access. And there are lots of opportunities for us to do that now. In fact, many of our providers and workforce are already sending us ideas on how they think we could do this better for their communities.
And our job is to monitor that is happening so that we can measure that accountability. So, the Māori Health Authority is interested interesting because we've got a commissioning function, we've got a co-commissioning function, we've got policy setting in partnership with Te Manatū Hauora, and then we've got monitoring function.
So it sounds complicated, but you've got a monitoring function. How will you know that you are a success?
How will we know that we are a success is that we'll be able to see the data, we'll be able to see that Māori are being prioritised inside those systems to make sure that we can see that the outcome has been, it's always been measurable. So it's about making sure that we get in there and monitor for that success, and where we can see that we're not moving in the right direction, we have to be able to turn the waka around and get it moving.
Is there any chance that if the ministry wants to monitor you in the same way that it monitors, say, Health New Zealand, or it did in the DHBs, that you could be pushed into sort of like a Pākehā format of health?
I wouldn't know how to answer that. I just know that from our point of view, we have a direct whakapapa up to being built from the ground up from a very ao Māori focus. We've got ao Māori solutions and we've been really intentional about that. So I don't believe we'll be pushed into anything. However, it would be fair to say that we're here in a partnership. We're here, we live in this country and we're tangata te tiriti and then we're tangata whenua. Those are the two kind of areas that we fall into. Our job is to make sure that tangata whenua have better services today, tomorrow, and
Okay.
I think one of the opportunities we've got, Simon, is we're set up with different settings as under the old district health boards. We've got the government has created an environment where we can be much more flexible about the way we use funding, including moving providers from 80 different service specifications to one that serves whānau, looking at how we can get into relationships that have a longer tenure, so providers have time and can have confidence to invest in their organisations.
I just quickly before we go. Do you feel the political pressure in taking up these appointments? Because it's a political hot potato. Margie?
It's political, but it's actually also the expectations of our workforce and our staff and our communities who are really hungry to see some change. So on balance, we're here to serve all those stakeholders, but importantly, our community needs to see a difference.
Liana?
Yeah, and my intention here, or our aspiration, is to make sure that our mokopuna inherit a better system than we did. And so there'll always be political pressures, but the pressure I feel mostly is to make a difference for our people, to make sure that, that we have lives that are full of, opportunity for good jobs, for better housing, to make sure that we partner up with all of those sectors that affect those kind of areas that actually really improve health. So there's some transitional stuff and then there's some transformational stuff, but we're on the,
and
made the right start.
Everybody will be watching you very closely. Thank you very much for your time today. Margie Upper from Health New Zealand and Liana Manuel from the Māori Health Authority, the new Māori Health Authority.
Can we just put a little bit of a tag out there to make sure everybody knows our new names as well?
Yep, go.
Te Whatu Ora for Health New Zealand and Te Aka Whai Ora for the Māori Health Authority.
Kia ora. Thanks for your time.
Kia ora.
Right, well, if you've got a news tip, please get in touch. We're on Twitter, Facebook and Instagram, or you can email us at nation@tv3.co.nz. If I can add. There will be no shortage of opinions from our political panellists, Patrick Gower, Shane Jones and Maria Slade. And Green Foreign Affairs and Trade spokesperson Goris Gutterman critiques the PM's trip